Hi everyone. So this presentation is going to be on the topic pulp and the anatomical aspect of the pulp. We know that a tooth consists of three main structures. What are they? Enamel, dentine, and pulp. Now, what is a pulp? So pulp is basically a soft tissue that is present within the tooth. Okay, and what is the type of origin? It is mesenchymal in origin. So mesenchymal literally it means that a loose connective tissue or structure that is derived from mesoderm. Now, there are some unique features to the pulp. So first feature is that it is surrounded by rigid wall. So that rigid wall is a dentine, and because of this rigid wall, it is unable for the pulp to expand whenever there is an injury. Now, the pulp is also susceptible to changes in the pressure, which results in the pain that you experience during the inflammatory process. Now, there is minimal blood supply to the pulp tissue. So, because of this, again, the repair chance following injury is also less. Now, it also has specialized cells that are present in it. So, we have the odontoblast and other cells like fibroblasts which are present. So, because of this, it has the ability to form dentine throughout the life. Now let's quickly discuss the developmental aspect of the pulp. So now starting with the buccopharyngeal membrane, once it ruptures, it forms the primary epithelial band, which further differentiates into dental lamina and the vestibular lamina. And the vestibular lamina will form the oral vestibule, whereas the dental lamina further progress to form the tooth buds. Now there are different stages in the tooth formation. So the first stage is the bud stage, and then there is the cap stage, and there is bell, and finally the advanced bell stage. Now in this slide you can see the difference between the cap stage and the bell stage. So in the cap stage there is an invagination that has been formed, whereas in the bell stage it has become more pronounced, and you can see the formation of ameloblasts as well as the developing pulp. So the pulp formation, it starts during the bell stage, and initially pulp was called as dental papilla. Only once the dentine is formed surrounding the pulp, that is when you call the pulp as pulp, and until then we call it as dental papilla. Now the histology of the pulp. So pulp has so many layers. So what are the main layers, major layers? Starting from the outside towards the inside. So we have the odontoclastic layer, followed by cell-free zone, which is also known as the veil zone. And then we have the cell-rich zone, and finally the core of the pulp, which consists of so many nerves as well as the cells. Now if you see the structure, we can say that the odontoclast is more in number in the coronal dentin. So that the coronal dentin is like the outside dentin will have more of odontoblast compared to the root dentin. And also the type of fibers which are majorly present in this pulp is basically the type 1 and type 3. In the peripheral aspect of the pulp, the collagen fibers, they have a unique arrangement pattern. So that is known as arrangement pattern is known as the von Korff fibers. So in this picture you can see closer to the dentine we have a von Korff fibers which are present. Now, what is the significance of knowing these fibers, information of the fibers? So the basic information is that there are more number of fibers which are present in the radicular pulp. So because of this, when you engage the pulp with a barbed broach in the apical area, very easy to remove the tissue intact. In one go, you can remove the entire pulp, and at the same time, there is higher chance of tearing the pulp. A quick recap on the blood supply. So, the teeth is supplied by the external carotid artery, which further give rise to maxillary artery, and the three main branches, that is the mandibular, pterygoid, and pterygopalatine. So, the mandibular will give rise to the inferior ocular branch, which further gives rise to the mental branches, mental artery, and incisive artery. Whereas the pterygopalatine gives rise to the intraorbital and the posterior superior alveolar artery. So, these further supplies major teeth or the segment of the teeth in these areas. The nerve supply of the teeth, so it is mainly supplied by the trigeminal nerve. So we have ophthalmic nerve branch, then there is maxillary nerve and the mandibular nerve. So now the maxillary nerve will further divide to anterior superior, middle superior, and posterior superior alveolar nerve. Now the mandibular nerve give rise to the lingual and the inferior alveolar nerve. Okay, and they further branches. There are further branches given out by these particular nerves, and they further supply the respective areas. Now, the innervation or the density is more towards the coronal aspect of the pulp when compared to the apical aspect, and majorly supplied by the A fibers. So, A fibers we have two categories, A beta and A delta. So, the A delta is the fiber group of fibers which results in a sharp shooting pain, whereas the C fibers give rise to the slow dull pain. So in this slide, it is a difference between the A delta fibers and the C fibers. So C fibers are the slow conductors, whereas the A delta fibers are the fast conductors of the pain. Now the venous drainage, ultimately the venous drainage happens to the external or the internal jugular vein, whereas the lymphatic drainage, it happens to the superficial and the deep cervical lymph nodes. Now in this slide, what is the effect of posture on the pulpal flow? So you might have noticed some of the patients, they do tell us that they have pain while lying down, not while sitting, but while once they lie down, they get the pain. Now what is the reason for that? In normal, when a patient sits in a normal upright posture, there is less pressure that is present on the head, and because of this the patient might not feel the experience of pain. And once he lies down, what happens is that there is an increase in the blood pressure of the pulpal blood pressure is increased. Now mainly that is because of the reduction or the removal of the gravitational effect, and because of which there is an increased blood pressure of the pulp, and also the sympathetic nervous system becomes inactivated when the patient is lying down. So whenever there is an inflammatory condition, there is release of enzymes which is taking place, and these enzymes will destroy the collagen that is present and release of kinins or bradykinins. Now these bradykinins are responsible for increasing the vascular permeability, and because of this what happens, the fluid will escape and they will get accumulated within the interstitial tissue or the interstitial space of the pulp. And because the space of the pulp is very much confined, there is increased pressure. And remember in the previous slide I had mentioned how there is a rigid wall, and because of this pulp is not able to expand. So this will ultimately result in increased pressure within the pulp chamber, and that is why the patient experiences severe pain during higher state of inflammation. Okay, now structure of the pulp. So we have in the tooth, we have pulp chamber and the root canals. Root canals is what you see in the roots, pulp chamber in the coronal aspect. And the radiograph, we can see the radiolucent area which indicates the pulp cavity. So we have 32 permanent teeth and 20 deciduous teeth. So in total, there are 52 pulp organs. Okay. Now let's discuss some of the important terminologies that you will come across while you go through the endodontics subject. So in this picture, you can see the access cavity that is prepared. So what do you mean by access cavity? It is nothing but you're clearing the area in such a way that you're able to visualize the canal orifices. So in this picture, you can clearly see the 3 orifices. Okay. Now the next major terminology, one is the apical construction. Apical construction, and then comes the apical foramen. So apical construction is the also known as minor diameter, and the apical foramen is the major diameter. So apical foramen is the apical most opening that you will see in the apical end of the root. That is through where the nerves and the blood supply happens. So it is the size is pretty huge, and it's almost like a funnel shaped, or you can also describe it as morning glory or hyperbolic structure. Now what is the distance between this major and the minor diameter? It is approximately 0.5 mm, whereas in the older individual it will be 0.67 mm. Now apical delta. Delta is the triangular area which consists of the apical foramen, then the accessory canals and the periradicular tissue. And so now there are various types or classification of isthmus. So in the type 1 there are canals but there is no visible communication, and in the type 2 there are two canals which have a connection. Now type 3 again, three canals connection with the connection. Type 4 similar to this, but they have their isthmus or the area of connection is more extended, and in the type 5 which has got the true connection. Now root canals. Now there are root canals classification, so veins classification. So in the type 1 there is a single root canal. In the type 2 you can see two distinct root canals, but in the end apical end it joins together. And then in the type 3 there is two distinct canals without communication. In the type 4 there is a single canal, but in the apical end it splits to two. Now how do you identify the anatomy of the pulp? So this can be done by clinical method and also in vitro method. After learning the normal anatomy, let's go into the variations that you might encounter. So in the picture, first one you can see germination. Germination is basically a single tooth. It tries to split into two. So like how conjoined twins are, exactly like that. And then there is fusion, where two teeth fuse together. And then there is chorodontism. Chorodontism is the enlarged pulp cavity or chamber. And then there is a dilaceration, that is the bending of the root. Now another variation that you might see is extra canals. Usually there are specific number of canals that you are expected to find, but sometimes there might be extra canal that is present, and this occurrence is most commonly seen in maxillary first molar, especially in the mesiobuccal canal. There could be a second mesiobuccal canal that is present. It is also seen in mandibular molars, which is only 38%, and also mandibular incisors as well as premolars. So the first will be maxillary first molar with the second mesiobuccal canal. And also sometimes a tooth might have an extra root. So that extra root is called radix entomolaris, and which is again mostly seen in mandibular molars, especially the distolingual root of mandibular molars are more likely to occur as an extra root. Now for variations in the shape of the cavity, what are the different variations that you might encounter in the shape? So we have curved canals. Now how do you identify a curved canal? So there are two different methods to identify this. So in the textbook they have described Schneider's method, and there is also Wayne's method. Okay, let's discuss Schneider's method. In this, what you're gonna do is you have to first draw a straight line from the coronal third of the canal, okay, and that will be marked as A, and the second line will be drawn from the apical foramen, exactly from the apical foramen. You should go in such a way that it will intersect the first line, and the angle that is formed in between will be considered to be the Schneider's angle, and this straight will be 5%, 10 to 20 is moderate, more than 20 it is severe curve. It's very similar to the Schneider's method, but just that it shows differences in the angles according to the curvature. So here also the first straight line is drawn from the canal orifice, not from the coronal third. Here it is from the canal orifice till the curvature point, and the second line is from the apex of the apical curvature. It is not from exactly the apical foramen, it is from the curvature of the apex of the curvature. From there the lines will intersect, and the angle is measured at the point of intersection. Okay. Another variation that you will see is the C-shaped canals. So they appear to be like a ribbon-shaped arc appearance, 180 degree or more. These are most commonly seen in the mandibular second molars and in maxillary first molars and mandibular premolars. Again, there are variations in this classification given by Fan et al. The type of canal that you will see is the S-shaped, also known as bayonet canal. Easy to identify from the radiograph. Commonly seen in maxillary lateral incisors, maxillary canine, maxillary premolars, and mandibular molars. And then we have the internal resorption as well as the external resorption. Let's start with the maxillary central incisor. So it is a single rooted teeth. So because of that, it will have only one canal, one root canal, and it will be present at the center of the crown. And next is the maxillary lateral incisors. Again, it is a single rooted teeth, so single canal. Maxillary canine, same way. Next is the maxillary first premolar. So it has two roots. Because of that, it has two canals. And in this, palatal canal will be slightly at a higher position than the buccal canal. And then the maxillary second premolar, which has only one root, so again single canal. Same goes for the mandibular second premolar and mandibular first premolar. And then the maxillary first molar. So in the maxillary first molars we have four canals which include the mesiobuccal, then the distobuccal, and the palatal, and a second mesiobuccal canal. And this mesiobuccal canal is the narrowest of all the canals, and palatal is the largest. Ideally there are only three canals, but in some cases there is a higher chance of finding a second mesiobuccal canal, so that is why I said four canals, otherwise it is actually three canals. And then the maxillary second molar, it's exactly similar to the first molar, except that the roots will be less divergent. It will be more fused when compared to the maxillary first molar. Having said all this, let's go into the laws which have been proposed for studying the pulp chamber anatomy. These laws you should be thorough with when you go into the endodontics practice. So first one is the law of centrality. So what does that state? It states that the floor of the pulp chamber is always located at the center of the tooth. So when you try to access a cavity, you should always remember the floor of the chamber will always be in the center of the tooth. Now let's see the law of concentricity. Concentricity, it means that the walls of the pulp chamber, they are always concentric, or they always coincide with the level of CEJ. So one deadline or the point, landmark point should be your CEJ. So once you reach the CEJ, the next step that you take will be into the pulp chamber. So that point should be there in your mind when you prepare a cavity, or when you Now next is law of CEJ. CEJ is the most consistent and repeatable landmark for locating the position of the pulp chamber. So if you want to expose a pulp chamber, you should go beyond the CEJ. But if you do not want the exposure, you should stop at least a few millimeters above the CEJ.